I'm not really going to rely on my slides, I don't think, but I'm happy to jump around and be interrupted as I go. Welcome. Good morning. Fancy meeting you here. I'm just starting.
Oh, good. Okay.
Hi.
Hello.
So, like I said, I'm not going to rely. Did I do that? No. Okay. I'm not going to rely on my slides, but they're there as a visual aid. Who's heard the term polypharmacy in the room? I was talking about it with a writer the other day, and words are so important to writers, and they were saying too many pharmacies. I mean, that's really what it technically means, but we don't say polymedication or. So it's a term that we really don't like, I think, because it doesn't mean what we think it means. But what we're really trying to get at is medication overload, the overuse or the excessive use or the burden of medication. And the challenge is that this is much, much more common as we get older. So we define polypharmacy just so we can study it and call it something. I have to take a step back and say I don't have any disclosures or conflicts of interest, but something I'm going to refer to a little bit later. I am funded by Blue Cross to actually do a study of reducing medication overload by de-prescribing. So I would argue that could be a little bit of a conflict because an insurance company would like to reduce medications for different reasons than I would, and they're paying me to do it. But this is a screenshot that I want to also draw your attention to. There's a website called Dollars for Docs that has been created by ProPublica, and you can look up any doctor in the United States and see if they've taken any money from pharmacy or from the pharmaceutical industry or the device industry. So I always show a screenshot that when you search for me, I need to keep looking at it regularly, but when you search for me, you won't actually find anybody. You'll find all these other people whose last name is Holmes, but not me. So that's because I don't have any money from the pharmaceutical industry, but I do have money from the insurance companies. So back to my presentation. So we arbitrarily call, it's not really arbitrary, but we call polypharmacy the use of 5 or more medicines. And the reason that number is where the definition kind of hits is that's really where we start to see an increased risk of drug-drug interactions, of falls, of other side effects that medications can cause when used in combination. So 5 or more is actually pretty common in the US. 42% of people 65 and older take 5 or more chronic regular medications. And somewhere on the order of 10 to 20% take 10 or more regular medications. This graph, I just want to point out just a couple things. This is data from Scotland, and we always think that, no, let me not go there. We think that maybe we're worse than other countries, but actually this is really generally a global problem, particularly in developed countries, that we over-medicate people, and as we get older, the medication burden just goes up and up and up. So this is the group 65 to 69, 70 to 74, 75 to 79, but 80 plus. And this is where you get into polypharmacy, technically. So look at, again, similar data to here, 40 to 50% of people taking 5 or more meds. But what's really striking is looking at the number of people who are taking more than 10 medications every day. And again, that goes up as you get older. It makes sense because as you get older, you acquire more medical problems, and medical problems are treated with medications, right? So some of this is understandable burden, but nevertheless, it's burdensome. So why is it so burdensome? Polypharmacy is a significant and a consistent risk factor for having an adverse drug event. So an adverse drug event is any reaction, whether expected or unexpected, that could be medication error, a side effect, a drug interaction, an overdosage, and anywhere between 1/3 to 2/3 of those adverse drug events are preventable. So we really have to focus on those preventable ones. And adverse drug events are a big issue with polypharmacy, but so are falls, dizziness, increased risk of hospitalization due to those adverse drug events. And
a little slower.
Oh, I'm sorry. I've got that Yankee thing going today. I'll kind of slow down a bit. Stop me whenever I do that. I'm originally from Michigan and upstate New York, and it's very difficult for me to slow down. So coming back to that, though, so if we define polypharmacy as taking 5 or more meds, almost half of the older people in the U.S. are exposed to it. Another definition that I think we would really broaden the scope is taking more drugs than are indicated. So in that definition, one drug could be polypharmacy. If you're taking a drug you don't need, that's some people would consider that polypharmacy. And another definition would be taking a medication to treat the side effects of another medication. So I'll go into that in a little bit. Taking higher numbers of medications also increases the risk that you're actually taking a medication that is considered high risk, low benefit, or shouldn't be used. And I'll talk about some of those medications in a little bit. And I talked about the fact that higher numbers of medications increase the risk of having an adverse drug event. Up to a third of people 65 and older living in the community get hospitalized every year for an adverse drug reaction. So that's a really big burden. And it's estimated that about 9% of all hospitalizations are medication related. And again, if you think that anywhere from 1/3 to 2/3 of those those adverse drug reactions could have been preventable, we're talking about a lot of potential preventable harm, potentially preventable. So let me come back to this idea of taking a medication to treat side effects of other medications. Everybody kind of nodded their head. You know what I mean when I'm talking about that, right? Now, it doesn't mean, I'm going to skip over that because I just covered it. It doesn't mean taking potassium because you're taking a water pill. That's appropriate. If you're, there are certain medications that are going to cause expected effects that need to be anticipated and counteracted. So potassium plus a water pill, that's appropriate. But a typical scenario is this. You go to your doctor's office, your blood pressure is 142/85. And your doctor says, well, according to the new guidelines, you have hypertension. And we need to get your blood pressure down to 120/70. So here's a water pill, hydrochlorothiazide, that's going to help you get your blood pressure down. I'll see you in, I don't know, a couple weeks if you're lucky, or maybe a few months, or maybe in 6 months, right? So you go home and you start this blood pressure pill, and your blood pressure goes down to 105/40. And you feel terrible, and you're dizzy, and every time you stand up, you think you're going to fall. You call the doctor's office, and they say, it sounds like you have vertigo. Let's go ahead and put you on meclizine for vertigo. So you go to the pharmacy, you buy the meclizine, you start taking that, and you just feel really sleepy. It does actually help vertigo a little bit, but it's also a sedating antihistamine type of drug, and it also causes constipation. So now you're constipated and sleepy, and the doctor says, well, maybe you should take some Senecot, and you think this isn't really that harmful. These are over-the-counter drugs. How harmful can it be? But it turns out that your home blood pressure was 125/70. The day you went to the doctor, now I always poo-poo this idea that, it's not real when you're in the doctor's office. Although, there is a lot of variation throughout the day of your blood pressure. And to react to that one reading right at that moment and put you on a drug that then led to the next drug, that drug caused a side effect. That side effect got diagnosed as a new disease. That new disease gets into your chart, never comes out. That gets a drug, that gets a new disease, and on and on and on. That's what we call the prescribing cascade. And I think that's really what I would consider the most harmful type of polypharmacy. It's the hardest to study because it's pretty hard to study in large groups of people to say this led to this, led to this. But in the individual patient, it's really easy to understand this, and it's very easy to avoid it. So anytime you have a new symptom or condition, the first thing you should always ask, and hopefully your doctor would ask, is, what's the new drug that just got started? What's the last drug I just started? Could that drug be causing this problem? So it always warrants a critical look at whatever's being treated, whatever's being prescribed. Any questions? Is that a little better pace-wise? It's like I'm expending energy. I need to slow down. Okay. Oh my gosh. I'm going to burn so many calories just trying to slow down. Okay. So I think we could agree that polypharmacy, whatever we want to call it, it's common, it's harmful, and maybe we can identify it. in a person. Okay. So let's talk about getting down to this sort of list of, before I get to that list of questions, I'm sorry. I talked about, I just want to highlight some of these facts. They're just kind of overwhelming. I already talked about adverse drug events happening in up to 30 to 35% of people over 65, and that maybe a third of them are preventable. But that's 5 million older adults in the US having a drug event in 2018, an adverse drug event. 750 hospitalizations every day due to medication-related adverse drug events. 150,000 premature deaths in the last 10 years. And again, I've mentioned that some of these are preventable, and some of these are about stopping this cascade. So what can you do to determine if you're exposed to polypharmacy or if a loved one is exposed to polypharmacy? So I kind of have these sort of 10 ways of thinking about it. There's plenty of other resources we're going to talk about that kind of help you walk through this. But the number one most important, critical thing I cannot stress enough is to always have a complete and accurate medication list everywhere you go. It really needs to reflect what you're actually taking. It could reflect what you're supposed to be taking and actually taking, but truly, on that list needs to be everything that you're taking. Bring it to every appointment. Some people we used to put it inside the fridge, like in a pill bottle, and thinking that EMT would look for it there. I think that's kind of fallen by the wayside. And you probably don't want to have your med list staring at you every time you open the fridge, but thinking about where does the EMT look for it the most. So if you ever had an emergency, where would they look for your med list? But keep it with you. Share it with your family and friends. They might be the ones who have to share it with somebody taking care of you. If you have diabetes, if you're on blood thinners, if you have a seizure disorder, if you have any kind of medical problem for which if you were not responsive and you got the wrong care, it would be harmful, you need an ID bracelet. But I want to point out the way that doctors are supposed to be thinking about your medication list when we see this. You know, this is the way a geriatrician thinks. When I see a medication list, I'm immediately going through the list and I'm saying, what's wrong with this list? The doses are wrong. I'm not sure how somebody's taking it. I don't have good directions. Why is this medication here? You know, I really want to critically examine every medication. So the second I see any medication list, I'm already going through all that in my mind. So the medication list is a really, really helpful tool to question your current care plan and the safety, indication, the need for your medications. Anytime you take 10 or more medications and you have 10 or more medications on the list, that also should be a bit of a trigger that, you know, I've talked about 5 or more being polypharmacy, but certainly 10 or more is really a useful trigger for a healthcare provider to say, that's a lot of medicines.
Excuse me.
Oh, yes.
So I noticed on your list it had vitamins. Would
Yeah.
you address that a little bit?
I will. I think I have it as number 6 or number 7.
Okay.
And I'm happy to go over there and come back. But once I get onto vitamins, I'm going to be talking nonstop. So I do want to be clear. Vitamins, supplements, herbals, everything that you're taking is a drug. If you're taking something that you're hoping will do something in your body, it's a drug, and your doctor needs to know about it. My biggest concern about the vast majority of supplements is that they are not regulated as drugs. They are regulated as food, as dietary supplements. So the Dietary Supplement and Health Education Act of 1991, I think, was written because a certain senator felt that it was very harmful that a family member was unable to obtain a certain supplement. And that supplement may or may not have benefit. But now broadly across the board, several, pharmacologically active substances, right? Actual drugs are supplements and are not regulated as drugs. So, number one, my challenge with supplements is that I do have a negative bias towards supplements, and it's because of that lack of regulatory control. So a good example would be ginseng. Ginseng is not a harmful medication. It can be useful in certain situations. Its benefit might be modest at best for things like fatigue or pain. It's used for chronic pain syndromes. It's used for some other things. But an independent lab did a study where they looked at 30 different products of ginseng, and the active ingredient of ginseng is ginsenosides. So they looked at all of the different ginseng products, and only one of them actually had the active ingredient in it. So all the other ones just were called ginseng, but because they're not regulated by the FDA, they don't have to prove that they have the active ingredient in it. Another commonly used supplement that's really supposed to be off the market by now is red yeast rice. Anybody heard of that? Yeah. So that's a statin. So red yeast rice. So when Merck discovered lovastatin, they discovered it on red yeast, as part of red yeast rice. They then synthesized it and grew it, created it themselves. So lovastatin, which was one of the first statins, is the statin that's in red yeast rice. So when you take red yeast rice, you're getting an unknown dose of lovastatin. It's probably 2.5 milligrams. The starting prescription dose is about 10 to 20. The benefit of red yeast rice is that you're getting a whole bunch of other lipid compounds that are not part of lovastatin, that are on the red yeast rice, and you're getting a tiny dose. So a lot of people will say, it works for me and I don't feel as bad as I do when I'm on a statin. It's because you're getting a micro dose of a statin. So again, supplements, I have this whole soap, I warned you that I have this soapbox. So supplements are drugs. They're meant to do something in your body. You're taking them because it's a drug. I like to give the extreme examples of, anybody has heard of the foxglove, right? You know what that is? Yeah, digitalis, very harmful. Digitalis, digoxin. So a drug used in heart rhythm disorders that could be lethal if taken to excess. Nobody markets foxglove and takes it as a capsule. I'm just saying that digitalis came from foxglove. There's a type of chemotherapy that came from tree bark, right? So when we think about natural things being healthy, they're not by definition healthy. So be very cautious. Always tell your doctor every supplement you're taking. They will not know what the active ingredients are. It takes a long time to find this information, and there is not good information. But there are some supplements that sort of trigger us and we say, okay, we got to avoid those. This comes from Consumer Reports. Consumer Reports did a really nice expose on supplements several years ago, and they said, forget about it. Get rid of them. They're costly. They don't work. They're not regulated. But these aren't terribly harmful. If you wanted to take these, you're okay, but are they really going to help you? The ones up top have been significantly and consistently associated with harm. And when I talk about megadose vitamins, I'm talking about mega doses of antioxidants that are 1,000 and more % of the US RDA. There's a very large study pooling all the data from 260,000 people showing that healthy volunteers that took very, very high doses of vitamin A, beta carotene, or vitamin E had a higher risk of mortality. It was a very tiny risk, but it was a significant risk. And if you're a healthy person, you don't expect a vitamin's going to kill you. So megadose vitamins are not healthy. Cranberry is probably not helpful. It's been shown to not be effective in preventing UTI, bladder infection. But there are some patients for whom it seems to work. It's certainly not harmful. Fish oil, on the fence, may be helpful, maybe not. We keep getting more and more data. Glucosamine for joint pain, not harmful, only harmful to your wallet. If it helps your pain, you would take it for about an 8 to 12 week course, and then you stop and only resume it when your pain comes back. It has not been shown to be effective, but there's a group of people that maybe have moderate arthritis that it helps for. lactobacillus, we're probably going to fall out of love with probiotics pretty soon, right? I think the negative press is finally mounting. Like, we're overdoing it. Now we all are just walking around with lactobacillus and nothing else. St. John's wort is an antidepressant. It interacts with other antidepressants, and it interacts with a whole bunch of other medications. The way it works as an antidepressant is the same way that SSRIs, like Prozac and Zoloft, work. So would you rather take Prozac and Zoloft where you know what your dose is, or St. John's wort where you're not sure? And then vitamin D, of course, we love vitamin D. We're probably over in love with vitamin D, but it's not harm. It's very unusual or unheard of to overdose vitamin D these days. You would really have to be taking extreme doses. So everybody probably should just be taking vitamin D. Okay, I got that out of the way then. My supplements, when we come to that, we can just say supplements. So one thing to keep in mind, even though I keep saying too many medications, there are certainly conditions for which you need to take several medications in order to keep that condition under control. So, here I'm talking about 5 or more, 10 or more is so bad, but heart failure, diabetes, heart disease, good examples that at a baseline, just to maintain where you're at and prevent further problems in the future, it's very likely you would be taking 5 or more medications as standard of care. And if you weren't, then you wouldn't be treated appropriately. Questions? Anything as I'm going? Then there's always been this move to create this thing called the poly pill, but it's never taken on because it would have a fixed dose of a statin, aspirin, a calcium channel blocker, I think an ACE inhibitor, and one other thing. So maybe one day we'll have one pill that has 5 drugs in it. That's the other thing I have to tell people to keep in mind. When you take a pill that has multiple substances in it, we really think of it as multiple drugs. 5 or more medications is also the point at which the drug interactions really pick up. And there are very few studies really supporting this because the way we study drug interactions is just 2 by 2 drugs. We just take a drug, another drug, and we see if they interact. But what about all the other drugs? What if you have 10 drugs and this interacts with that, and that interacts with that, and that interacts with that, and it's all in ways that end up becoming unpredictable? When you take 10 or more medications per day, the likelihood that you have at least one drug interaction is 100%. But is that drug interaction significant? Is it going to cause you harm? That's very difficult to say. The drug interactions that are really severe, that land you in the emergency room, those are pretty low. And there is one study that showed that about 4% of people over 65 were exposed to one of those very significant, potentially harmful drug interactions every year. Exposed, but we don't know about going to the ER. If you're on things like blood thinners, warfarin, digoxin, seizure medicines, antifungal medicines, some of them, methadone for chronic pain, those are major culprits of severe, very worrisome drug interactions, and they interact with drugs just across the board. So you have to be very cautious when you're on any of those. It's so important to know why you take your medications. When you have that med list, have the reason for each medication. And always keep in mind, if you're taking more than one drug for the same reason, are you duplicating, the drug itself? One of the most common ones I see is when somebody else prescribes a non-steroidal anti-inflammatory, NSAID. And anybody know what an NSAID is? Right? Ibuprofen, naproxen, Aleve, Motrin, Advil. And so the patient forgets to tell the orthopedic surgeon that they already take Advil every day. And the orthopedic surgeons, and I don't know why I need to ask them, they love meloxicam, Mobic. It's a prescription only, and I think people love taking prescriptions rather than over the counter. The copay's cheaper. You feel like, you've gotten something from the doctor, but ibuprofen's just as effective as Mobic. So the orthopedic surgeon prescribes Mobic, and then they come to me and they're on Mobic at maximum dose and Advil. And that's really harmful, potentially to bleeding risk, kidneys, blood pressure. So anytime you're taking 2 drugs for the same reason, that's sort of okay, are these the same drug, or am I really, so a good example of where that's appropriate would be diabetes. You might need to take 2 or 3 different types of medicines for diabetes. Okay, I mentioned at the end that it's now a lot easier to find out if you have drug interactions. You don't have to rely on somebody to search for it for you. Drugs.com, WebMD, Medscape, RxList, all of those websites have freely available drug interaction search engines. I always forget if it's RxList or drugs.com, but you can also use their pill identifier. So if you've ever mixed up your pills and it's a white pill with the letters, BP 250 on it or something, you can look that up, you enter it, and it'll tell you what that medication is.
You can actually just put it in Google.
Yeah, you can just Google it. You're right. Google's amazing.
Yeah, but a lot of older people don't go that route.
That's right.
You can go into the pharmacist, right?
You can go to the pharmacist.
Right.
But I think most of my patients would look things up on the internet. It's surprising. It's interesting because I think a lot of our trainees think that too, and so they don't give instructions that are technology based. And upwards of 70 to 80% of older people will use the internet to get that information. So I would rather say, hey, look that up. I would rather not, I want people to have it in their own hands, so that they're not waiting.
But what is that called when they actually can go to the pharmacist?
You can literally go in there and ask them to look it up.
A lot of people don't know that.
Yeah. And don't go Monday at 5 p.m. But, and the technician can look it up. So the pill identifier, they have a very quick, easy pill identifier. All they have to do is just type it into there, which if it's Walgreens, CVS, or whoever, they have their own, system. The other reason that's so important for them is that when they, you may or may not notice that when they fill your prescription, most pharmacies now have the pill image on it. And so if you still have all that, I don't recommend keeping all that paperwork that says this drug can cause rash or death, right? You should ignore that part that says can cause this whole page of things. But there is a picture of the pill, and that's super useful later if you get confused about your pills, or if they change the pill, or if it doesn't match the picture. So yes, you can go there and do that too. Avoid ineffective drugs. And I put a box here with just some examples. There's a list of medications that we're really not supposed to be prescribing in older people. There's nothing magical that happens when you turn 65, when you were 64 yesterday, right? It's like suddenly you can't do all these things that you did before. Like you took, Valium every day of your life, and then you turn 65, and now you can't have Valium anymore, right? But that's the way we sort of treat it. But it's a helpful point at which we realize that we need to change our approach to medicines. And there are several medicines that are high risk, low benefit, have not been shown in older populations or have not been shown in any population that the benefit outweighs the risk. So some good examples, antihistamines, I put them a little out of order than on here, but this is the bane of my existence, Benadryl, over-the-counter sleep aids. Those have sedating antihistamines. And over short-term use and long-term use, those increase the risk of confusion, falls, and long-term functional problems. And that's been repeatedly shown, and it's amazing. Benadryl is just out there for you to get. Now, Benadryl is perfectly appropriate in the setting of an acute allergic reaction. It's going to work better, faster, and more completely than in a lot of the other antihistamines, including the ones that aren't sedating. But for other causes, for allergies, which everybody in Houston has, and certainly for sleep, we avoid it. Oh. So I put that there, Z drugs, and that's here under sedatives. Benzodiazepines like lorazepam, Ativan, Xanax, diazepam, and then Z drugs. Zolpidem, azopiclone, and I always get my third Z wrong, but Sonata, Ambien, and Lunesta. Bane of the geriatrician's existence. Do they make you sleepy? Yes, very. But when they actually look at, on average, it's pretty shocking to see how not that effective they are in groups of people. So on average, they increase sleep duration in a whole evening about 20 to 26 minutes. They also decrease the latency to falling asleep by about 9 minutes. That's probably where it's at, which is you're lying in bed awake and you're not falling asleep. And it will help you fall asleep a lot faster. People who take Z drugs like Ambien have a 3 times higher risk of falling and breaking their hip compared to people who don't take them. So what I really try to focus on is, what is somebody's baseline risk? What's important to them? What matters the most? For somebody who says, there are people who say what matters to me the most is not to break anything. I don't want to fall. I want them off Ambien. And it takes a very long time because we don't have a good substitute. There are not very many, the challenge is there are really not safe medications that help you sleep. There's no medication that's going to be without risk. It's just about minimizing that risk. So that's on the list of drugs that we're not supposed to ever prescribe. And when we do prescribe Ambien, we get a nasty note from the Medicare Part D plan. And sometimes it's not even approved. We have to call the pharmacy to get it authorized because they don't even want us to dispense it, right? And I'm going to talk about a resource for that at the end.
Let me ask you this. Of course, you hear so much about that, the 8-hour sleep or 7-hour sleep, your body repairs. So we saw this idea that if you don't get that sleep, you are aging faster, you have all kinds of problems. And so I can see why, all these sleep aids, are so popular. But at the same token, I can also see that in people who have been taking long term, and I'm not a doctor, they are more susceptible to dementia, Alzheimer's, all those memory issues. It's not the breakage of the bones.
Right, it's the decline. Yep. I think we have sold ourselves on the idea that 8 hours sleep is needed. And the problem that we all don't want to acknowledge is that as we get older, we are unable to sleep that long. It doesn't mean it wouldn't be helpful, but it really means that 5 to 6 hours of sleep per night is an average for an older person, unaided. And this idea that it needs to be 8, 9, 10 hours has to go. There are several long-term studies. One, I think the most compelling study is they took people who were 75 and older, so they didn't start like in middle age. They took 75 and older. They had no dementia, no memory impairment, no functional impairment, completely independent, doing everything they need to do in their day-to-day, 75 plus. They followed them for up to 10 years. This was a very long-term study done out of Pittsburgh. I mean, national study, but they ran it there. And, of course, people get all kinds of things and illnesses and whatnot. But even controlling for all that, people who took these drugs that are sedative, so the benzodiazepines, the Z drugs, or drugs that are sedating, like the antihistamines and those kinds of drugs, they had a significant decline in their physical ability, and they had a significant decline in their mental ability. And they had a higher risk of dementia. They had a higher risk of falling. And they had a higher risk of needing help in their day-to-day activities. So I think the challenge is that, the problem is that we don't have good substitutes, and it's about embracing having the most minimum risk possible while knowing that also means, that can mean poor sleep. And it's a very difficult balance. I don't have it up here, but barbiturates are on this list. They've been overused in the past for sleep. We really don't use them very much anymore, except for seizures and tremor. Antipsychotics that are used for the behavioral symptoms of dementia, so when somebody's agitated, that's really considered inappropriate as a first step. It really should be addressed with non-medication, and that's been shown over and over again. Muscle relaxants, another bane of my existence, not shown in any population to be very effective. they don't really do what we think they're doing. I think what they do for the people that say, well, it really worked, is they kind of zonk them out and then their muscles are relaxed. So Robaxin, Flexeril, methocarbamol, the list is about 5 or 6 drugs long. I usually see those prescribed after an acute injury, like a fall or something that, lands you in the ER or a surgeon's office or whatnot. And again, I really think the mechanism that it's working is that it's actually so sedating, but very high fall risk with those.
Excuse me.
Yes, ma'am.
And while we were talking about sleep, what about melatonin?
I actually think melatonin is reasonable to try.
Is what?
It's reasonable to try. I try not to give what I would call, I try to preserve the placebo effect and not give what I would call a nocebo effect. It does not often work. But when it does, I'm so happy. Because of all the things that we could use, it's the least harmful. If anything, we're not sure that there is much harm. Some people use very, very large doses. I really think it's reasonable to start around that 2 to 3 milligram dose and really not exceed 5 to 6. I don't think it's not harmful to exceed that per se, but it's not necessary. Really 5 or 6 milligrams should be enough to kind of overwhelm what your body would normally make. And melatonin, as you probably know, is already what your body is making in response to the darkness. So it's basically telling your body it's time to go to bed.
And I've also heard that sometimes your body stops producing as much melatonin if you're taking it regularly.
There is the possibility of suppressing if you're taking more than 5 milligrams every single day. I haven't seen any evidence that it needs to be weaned. I'm curious about that, and maybe there's just not enough people who've taken it. But if that were the case, then the idea would be if you ever decided to stop it, you really could have just a very messed up circadian rhythm, that you would want to wean it potentially slowly.
Can I ask you in relation to this melatonin? Now, what about the new age thing about light therapy? Producing melatonin, would that?
Right, like light therapy during the day and then dark at night. That is a fundamental principle of what we try to do in the hospital to prevent delirium. You need light during the daytime, you need dark at night. And this is part of why people do not sleep in the hospital. You're being bothered every 5 minutes for blood pressure and meds and whatnot. But we leave the lights on all the time. During the day, we've got the shades closed. So we do some really low-tech things. My geriatricians who do consults at Herman, we just walk in and we pull up the shades and bring in the bright light. We do tend to use a lot of melatonin in the hospital. There is some really good data that it's helpful in certain settings. And again, it's not harmful and it doesn't interact with other things that are happening. And light therapy has also been shown in the nursing home setting where people are often indoors and never getting outside. So there are some studies where they use UV light indoors and others where just go even lower tech, just go outside for 15 minutes a day.
I've always been curious, when you go outside, how much skin do you need to expose? Is your face enough?
No, supposedly you would probably want to put UV protection on your face because we tend to have a lot of sun exposure and that's where skin cancers tend to happen. And any dermatologist would say don't go out and get light for your vitamin D. But honestly, 15 minutes on your arms and legs is adequate. But that's kind of a lot for some of us. As somebody who never goes outside, I think 15 minutes feels like a lot. So I take vitamin D, and I use UV everywhere all the time. So yes, I think a dermatologist would probably not agree to go out and get sun for your vitamin D. But there's 2 aspects of the phototherapy. It is the vitamin D, but then also the, just keeping your sleep-wake cycle intact. You can cover yourself in UV protection. It's still beneficial to realize it's daytime now and it's nighttime at night. What other things? Oh, some diabetes drugs are considered unsafe as you get older because they become longer acting. And we see a lot of harm from those where blood sugar drops. Short-acting insulin is considered on its own. Like if you're only taking an insulin sliding scale and nothing else, that can be very harmful. Can lead to major dips in the blood sugar. Any question about some of these medications? This all comes from a list called the Beers list. The guy who created it was Mark Beers. And sadly, he actually died at Beers. He died at the age of 52 of diabetes complications, so he never got to experience being older. I was always curious what he would have done, but this is a list that was created in back in the 90s, and we update it every few years. And so the American Geriatric Society publishes this list. Every couple years it gets updated, and we all have these big debates about it. So these are just some highlights from that list.
How do you feel about the CBD stuff?
Oh man,
Pushing?
I should have had a whole CBD section, right?
Does that interact with all the
There are a lot of drug interactions with CBD. That's one of the challenges. I really do think that doctors are going to have to go, maybe if they would have a big CME conference in Hawaii, we would all go or something, right? We rely on our colleagues in other states who are a lot more knowledgeable where marijuana is legal. So the issues there are even more challenging because are they taking THC or CBD? So CBD is everywhere. In Texas, CBD is not supposed to have THC. And so are we familiar with these terms? Yes. Okay. So THC, tetrahydrocannabinoid, I think. I'm making that up. But, that's the active ingredient in marijuana that has the hallucinogenic and whatever else properties, right? But CBD is cannabidiol, which can come from a different plant, can come from just the hemp plant. It's the oil that doesn't have any of those properties. The challenge is that both medications have some significant uses, and there are some important differences. The CBD does not help nausea. It does not help you improve your appetite. If you have particularly like cancer-related weight loss, you really need THC, not CBD. So having that medically available would be useful. It also then makes it challenging for when to use this and when to use that. CBD does have some role, and it's emerging in the treatment of pain. There's a pharmaceutically prepared product that's used in epilepsy in children. It has some potential role in agitation, we think. But the problem now, of course, is that because it's so widely available, the cart is so before the horse, I just don't know that we're ever going to be able to study it anymore. And again, its regulation is a little bit different, but it's so unregulated compared to prescription medications.
so just like a supplement? You
Just
would say,
very similar to a supplement. You'd say, am I getting what I'm getting? I think it's going to be a little bit more regulated, though, in terms of the percent of THC. So at least if it reports that, it has to report that, you could feel comfortable that you're not getting a product that's like half and half. But a good example is we have an independent pharmacy in the building where our clinic is, and it's so useful to have them up there. But they're selling CBD. So I went up there and talked to the pharmacist, and I said, well, my patient wants to come up here and talk to you about CBD. What dose do you think I should tell them to take? And he's like, I don't know. I'm like, well, I don't either, and they're going to come buy it from you. Can you look up their drugs and at least tell me that anything interacts? And they're like, I don't know. I'm like, I don't think you should really have this here if you can't give people advice about it.
Is he a pharmacist?
Yeah, the pharmacist. So it's always good to, if you're going to try CBD, it's cannabidiol, and you should look up that with all your prescription medications. And you can look up interactions with cannabidiol just to make sure, because it does have a lot of drug interactions. Yeah, CBD. You need to have a whole talk on CBD. Any other questions about harmful drugs? Why? I already said this. Why are you taking each of your medications? This will help a lot of problems along the way. If you have a medication that treats a condition that you don't even have, why are you taking it? So it might be that it's appropriate. I'm not saying it's not appropriate. I'm just saying the more informed you are about why you take your medicines, the better off you will be.
It's because of doctor prescribed it.
Right. To me, that's not an indication. Right.
But people don't know.
And it's okay to say to the doctor, why am I taking this medication? And if the doctor says, I don't know, then what? Right?
A lot of people don't ask.
Yeah. Right.
Just believing the doctors.
I know.
You go to more than one
before you
doctor
know it.
too.
Right. And a lot of people go to multiple doctors who don't talk to each other.
That's right.
But I
They
think
don't even look at the list.
That's right.
They don't.
I think people need to feel empowered that this is information, this is your life. This can be life or death. We talked about how important these reactions are. It is perfectly acceptable to demand an answer to that question. And then how long should you be taking them? So there are some medications, I always use the proton pump inhibitor as an example, Prilosec, omeprazole. You had some heartburn last week, your doctor said to take omeprazole. It's 5 years later. Now what? You're not supposed to be taking it for 5 years. Your doctor probably only meant to say, take a 2-week course and then let's just see. But they don't take the time to educate you about that. So
How about Nexium?
Nexium is also a proton pump inhibitor.
Yeah, every day? Or years?
That's the question. So the issue is, why are you taking it? If the condition is like having an ulcer, having Barrett's esophagus, abnormalities that are much more severe, those are people who are more likely to be on it very long term. But long-term use of Nexium, Prilosec, Acifex, Protonix, Prevacid increases the risk of osteoporosis and broken bones. There's a study suggesting it increases the risk of dementia. And there's a mechanism by which that makes a little sense in terms of absorption. And it also increases the risk of chronic kidney disease. Chronic kidney disease. And it also impairs your absorption of vitamin B12. So we have all these people taking acid blockers who are now B12 deficient and don't know it. So a proton pump inhibitor for simple heartburn is meant to be a self-limited course of treatment. If you have daily heartburn, it's worth seeing a GI doctor to figure out why you're having daily heartburn. And sometimes it's a single episode that can be controlled, treated, and done, and sometimes it can't. And the thing I'm going to talk about at the end, the Canadian Deprescribing Network, I highly recommend looking on there because there's a patient brochure all about acid blockers. Do I need this acid blocker? The Canadian Deprescribing Network. And I'll show you that in just a minute. I'll show you a screenshot of it. Okay, good. We get to skip supplements because I spent so much time on that. Okay. And I always recommend every ill has a pill, right? For every ill there is a pill. But there is no pill that is free of side effects, free of harm, easy to take, no problems whatsoever. So is a pill always the right answer? So whenever there's a condition you're discussing, your doctor thinks that you want a medication. Like you're saying, I'm having this horrible back pain, but what you want to know is, why am I having back pain and what can I do about it? But the doctor says, here's some Mobic. But you're already taking Advil every day, right? This is the scenario I mentioned earlier. Medication isn't always the best first choice. There are sometimes alternatives. Arthritis is a good example. Is there a type of exercise? Is there physical therapy? Is there something I can be doing? Is there, heat, massage? Could I be doing a limited course of Tylenol before I jump to, morphine? Just exaggerating. Or CBD in the future. In the future, I'm sure we will really figure out when to really embrace CBD for different types of pain, whether topically or orally. High blood pressure, do we really have to treat it on this one visit when it was high for the first time ever? Is this something that we can monitor? Am I a person who adds salt to everything I eat and then eats potato chips and then adds some more salt? I have a colleague in geriatrics who actually salts his potato chips. It's just like, first of all, he eats potato chips, which I'm jealous, and then he salts them, and I find it so amazing. But some people are not salt sensitive, but some people, you eat a potato chip and your blood pressure goes way up. If that's you and you reduce salt, you may have avoided medication. Diabetes, again, we really have to focus on lifestyle control. I see so many people coming to me that a different doctor started them on a diabetes drug when their diabetes was really pre-diabetes. We're not even at a point where we need to be treating it. And furthermore, the exercise completely went off over the last 6 months, or it's after the holidays, or it's whatever. And high cholesterol. I really have a bias about not treating high cholesterol as a primary prevention measure when you haven't had heart attack or stroke and we're just treating that number. And finally, the cardiologists have agreed that when you're 75 and older, we have never shown benefit from statins for people who've not had a heart attack or stroke. So they say it would be reasonable to take a statin, but it would also be reasonable not to. So if a cardiologist is saying it's okay.
Well, statins have a lot of other side effects that are good, right?
Well, it has other beneficial effects and it has other harmful effects. And the reason we prescribe the statins is those other effects, the stabilizing the blood vessels and helping the inflammation in the blood vessels. Like that's really how they work, not so much by lowering the numbers.
How about just eating better?
So if sometimes eating better does improve cholesterol. I mean, I will say, I think lifestyle changes are really important. Statins, of course, will lower that bad cholesterol much more than any lifestyle change. There's no doubt about that. But the real issue is that we haven't shown, if you have no known heart disease, no history of heart attack, no history of stroke, mini stroke, all of those things. Even in younger people, we have to treat hundreds of people to prevent one event. And we have to treat them for more than 3 to 5 years. But we've never shown that people in their 80s and 90s actually benefited from being on a statin. So it's so uncertain that the NIH is now funding a big, huge trial. They're throwing a bunch of money at a study only looking at 75 plus, putting people in 2 groups, statin or no statin. So that's how uncertain it is. There's this $80 million study that's about to start to finally decide if a statin helps older people. And in the meantime, we're just prescribing them all over the place.
How
So,
many people are? Do you know the percentage of people?
of people on a statin, I don't know the
Maybe like
latest numbers.
30%?
Yeah, upwards, 38, 40%. With the guidelines that had come out in 2012, we started prescribing them all the time. And it was based on your 10-year risk of heart disease. But by definition, a 75-plus-year-old already has a 10-year risk that meets the criteria for a statin, regardless of the LDL cholesterol. So we have some cardiologists at UT who really focus on geriatrics. They only treat older people, and they take a sort of, we embrace them in our division that they're geriatricians. And one of them says this thing to all of his patients. He's like, you know, you've gotten to the age of 80. The statin may or may not have gotten you here. But now it's all about victory laps without the statin. So to him, it's like, we don't even know that the statin helps you after that. But we do know that the rate of muscle pain, fatigue, and all of that is a lot higher than were reported in the clinical trials. So that is upwards of 10 to 20% of people who really get significant fatigue and muscle pain and such from statins. Okay, and so again, always good to talk about lifestyle because that's something that we can take control. Take your medications as prescribed, unless you don't, but tell your doctor. So I'm not all about take this medication, but it's like I really just need to know how it's being taken. So one of the most harmful things that could happen is you're on a blood pressure pill, but you're really not taking it. And you go to the doctor, and then the doctor says, well, your blood pressure is not controlled, so we need to double that pill. Well, then now they send in the new prescription for the doubled dose, and now you're going to start taking something that you weren't even taking before. You're going to bottom out. So it's better to be honest with your doctor. You're not going to ruin their day. They might be, at worst, I know people are afraid to tell their doctors these things. Maybe they'll chastise you for a moment, but they'll still just go home and do whatever they're going to do.
Anyway.
They'll love you anyway, exactly. If they're taking it that personally, you know.
Find a different doctor.
Yeah, like, wow, you're really taking it to heart. This just shows that, you know, you're in good company. Nobody takes their statin for very long. Only 60% of people even filled the statin prescription in the first place in this one study. And up to 3 years later, only 20% of people were still taking it. But then they didn't tell their doctor. And you know, it's best to stop a drug under your doctor's advice because some of them need to be tapered or might interact with other drugs. A rule of thumb that your healthcare provider should use is that anything that affects your brain or your heart, you would probably want to wean that down slowly. the vast majority of drugs could just be stopped, but when it's uncertain, it's good to ask. But anything affecting the brain or heart, wean. And anything,
Sorry.
oh yeah,
Isn't it also true, though, that if you stop a drug without your doctor's advice, that Medicare can also say that you have not adhered to the prescription?
yeah, they will say that, but then what will happen to you? Nothing. They will not come to your door and take you away. What they will do is they will send a nasty note to your doctor. So even if you don't tell your doctor knows. So I get these letters all the time. Your patient is not adhering to blah, blah, blah on their list.
I am so sorry to interrupt. Did any of y'all drive the Aston Martin that is parked in the fire lane?
Aston Martin? Aston Martin, anyone?
There's an Aston Martin parked in the fire lane. No, nobody?
Well, maybe James Bond just had to like run in and do something. I'm sure he's not going to be in the fire lane for long. He's just got to come in. Okay, so, and of course antibiotics, if you are going to take them, then take them. Well, that's just my little plug. I could talk about antibiotics all day long, but I'm not going to do that either.
Let's do.
No. Although you could have somebody talk about the overprescribing and overuse of antibiotics and all the problems we're causing there, but.
But if you have pneumonia, you need them.
Yeah. Potentially. Unless you have a viral pneumonia. So we've already kind of touched on this quite a bit. It's very helpful to know whether your medications are of benefit, right? Is there information that can help you with that? It's worthwhile asking your doctor. We think that medications eliminate a condition. That's not the case. So even the osteoporosis drugs that we really kind of wring our hands over, it's not that they completely eliminate your risk of fracture. It's that they cut that risk in half. Now, if I tell you it's a 50% reduction in breaking a bone, that sounds like a lot, right? But what if your risk was only 3%? So your risk went from 3% in 10 years to 1.5% in 10 years. That's the way you really need the information. What is my risk and how much is my risk going to be lowered by taking this drug? So statin's a great example. The ads always say 30% reduction in the risk of heart attack. But your risk was only 10%. I mean, I say only, 10% is a lot, but going from 10 to 7% is a lot different from saying 30%. So that is generally the benefit of a statin, a 30% reduction. So you have to think about where you started and where you ended up. So if you had a 24% risk, you're really just getting down to about 16%. The statin does not remove your risk of heart attack. It just lessens it. So there are still people who have heart attacks on statins, and there are still people who don't have heart attacks who didn't take the statin. It's very challenging to make these decisions. And if you think about that, that's just one drug. Imagine when you're on 10.
Well, why not take it preventatively?
What's that?
Why not take it preventatively?
The statin?
Yeah.
I think in part because it's not without risk and it's not without harm. So a couple of the studies showing the long-term muscle side effects, one of them actually looked at the longer-term risk of joint pains, muscle pains, and later fatigue and falls. And there isn't...
That's just old age.
I feel like you're being devil's advocate over there. No, I would not call those things normal with older age. I would not call those normal. And so if a drug increases those risks, they are more common as you get older, but the medication makes it even more common. So I think that's the challenge. It's always that risk benefit. So some people take statins and feel perfectly fine about it. And this is the other thing to acknowledge. It's not like I stopped the statin in everyone. I have many patients who are really of an age that even a cardiologist wouldn't start a statin, but they were already on the statin. They've been on the statin forever. And we say, well, do you think the statin's causing any trouble? No. Are you able to afford it? Yeah. Does it interact with any of the medications? No. Is it burdensome to you in any way? No. We just keep it. We keep it until it really doesn't make sense to keep it. So it just depends on, there can be a point in time where it makes less sense to take that preventive approach and keep the statin on, and then we talk about getting rid of it. And certainly for people who are higher risk, who've had heart attack, stroke, or at very high risk of heart attack or stroke or recurrent, then that equation's different. Good zoom tight, sorry. Okay, so let me tell you about these resources. This is this is the kind of brochures they have at the Canadian Deprescribing Network. And it's publicly available. The government in Canada supports it. I think I didn't put the actual URL on there, but I can send it to you if you want. But if you just Google Canadian Deprescribing Network, this is what comes up. And for all of those drugs that we talked about that are sort of high risk, low benefit, the proton pump inhibitors, the acid blockers, but this is all about the sedatives, the Z drugs, and the benzodiazepines. It's a 12-page brochure. It walks you through what the benefits and risks are, how to get a good night's sleep without these medications. And they also have a 19-page brochure just on that, how to get a good night's sleep. So if reading the 19-page brochure doesn't work, I don't know what will. But it has a lot of things that are really around cognitive behavioral therapy for insomnia. And this is the key message that they make. Cognitive behavioral therapy for insomnia was shown many years ago to be more effective than medication. The effect is actually stronger, but it was never covered by Medicare. So we never provided it. You had to go pay for it. It's increasingly becoming available, and there are practitioners who are taking Medicare and doing it. It's worth doing a course of CBT, not CBD, but CBT, when on one of these medications to see if it can help reduce it. And our neuropsychology group at UT has a cognitive behavioral therapy group class. So they do it in a group format, I think because of reimbursement. And it's an 8 to 12-week program. So that's the Canadian Deprescribing Network. They have brochures. They're wonderful. It's great. This is really awesome. The National Institutes of Health has this resource called Tips for Talking with Your Doctor. And they have this whole thing about getting ready for a doctor's visit. They have medication lists. They have questions you can ask, you should and can ask your doctor about your medications, like, is it effective? Is there an alternative? All this bit. So that's publicly available, very useful. I put the link there. And I already mentioned that you can look up drug interactions on all kinds of websites. So I just want to drive home that overmedication is really common and harmful. That you need, a person on 5 or more or 10 or more medications really needs to be the owner of that list, knowing why they're on everything. And that it's perfectly acceptable to go to your healthcare provider asking for a review of your medicines. Are these really necessary? Are there any that I can reduce? Could you do a checkup of my prescriptions? They might want you to spend a whole visit only doing that. You might not get any time to talk about any other issues. And the way we are addressing this at UT is we are doing that study where we have a clinical pharmacist go in the room with our patients. They are reviewing all of the medications in detail. They have geriatrics training. They're talking about the ones that they think are more harmful or unnecessary, and they come to the doctor and say, I think this is harmful or unnecessary, and this is how I would get rid of it. And then we go talk to the patient, and we all agree. And then the pharmacist monitors that.
How do you sign up for that?
That's actually a study we're doing because we're trying to show that it's cost effective. It's currently not covered to do that kind of practice. And pharmacists aren't able to bill Medicare for their services directly. So we're trying to show that it would be worthwhile for them to do it. And we're doing it right now in a fashion where we have half of our patients getting the usual care, and we have half of the patients who meet these criteria getting the pharmacist. Everybody wants the pharmacist, of course, but we're really trying to compare and show.
How long
But-
is that study gonna be?
It's going to be 2.5 years,
And it started when?
November. There are also certified geriatric pharmacists that will do medication review. The challenge is that most people who have Medicare Part D, there are some criteria that you need to meet in order for a pharmacist to be able to do a review. Sometimes your Part D plan did a review and you didn't even know it. They sent the letter to your doctor. But there is, you can actually look up, again, just searching on Google, you can say, how do I find a geriatric pharmacist? I think that the website that used to link out is not anymore, so I won't give you that. But There aren't that many in Houston that I know of. And again, they have to contract through a doctor's office and they have to bill through a doctor because they can't bill directly.
We expect our regular pharmacists to just be able to glance at our list of medications and help us.
I think it's reasonable, but they're probably overwhelmed.
They're busy, but
Yeah.
they should be able to.
And whether
maybe
that
catch
leads to,
something. If your two different doctors prescribe things that could be harmful, should they catch it? Because we just, you just don't know.
I think they have the ability to catch it. I think my issue is that the pharmacist is the most underutilized resource we have. And unless the doctor's office is communicating with them, what happens is then you go back to your doctor and you're like, my pharmacist said that this dose is too high. And imagine the look on your doctor's face, right? Like, really? So I don't know why more doctors' offices are not taking advantage of the pharmacist being there. And this is my theory about having the pharmacist in clinic. I think having the pharmacist in clinic and be part of the team is how we're going to impact this medication overload. Having been a Walgreens pharmacist, I will tell you, I would just be happy if I survived every day without a panic attack. Just getting all those prescriptions out and not making a mistake. The volume of work that your pharmacist is doing is ridiculous, but it's also well below what they're trained to do. If anything, they should be sitting in an office doing consultation all day long. Somebody else can be filling those prescriptions and checking them. A computer can do that. A robot can do that. Robots do it in the hospital. So the pharmacist should be available for consultation.
Yeah.
But what they really do is they say, do you have any questions about your medication? That's them giving you a consultation.
Exactly.
Yeah,
At the drive-thru.
right. At the drive-thru, exactly.
Actually, though, I'll just say that recently I switched to a new pharmacy, and they actually called me to discuss
It's very
my
good.
medications and if I understood. So
That's great.
thought that was quite interesting. 'Cause
Which
it never-
pharmacy was it?
Never ever happened. It was a Walgreens in Pearland.
That's great.
And I was a CVS.
Yeah, that's great.
My dad, yeah.
That's fantastic.
All right, guys. Well, real quick, I just want to, for those who need to leave, we may have a second for a few more questions, but I want to respect everyone else's time and Dr. Holmes as well. But just want to say, let's give Dr. Holmes a
Thank you. Thank you so much. Thanks so much for your attention. Thanks.